Professor Dr. Yaqoob Magdi is a professor of nephrology. He's at St. Bart's and London NHS Trust. He's a consultant there, and he's going to enlighten us on the origins of global epidemic of diabetes, cardiovascular, and chronic kidney diseases. Let's give a warm applause to Professor Yaqoob Magdi, please. I just have a small announcement. We have timekeeper young ladies sitting here, and they are displaying the time in big, and we will try and stick to this time. Thank you.
Thank you very much, all the panelists and all my friends and my colleagues from Pakistan who have traveled all the way from there, particularly the vice chancellors. And I met you all in the Royal College on Monday, and I'm very grateful that you have all made this journey. And hopefully, people like me who actually got everything from Pakistan. I am what today is because of my country of birth and opportunities which are arising as a result of our High Commissioner here would allow me to pay back what I gained from that country. And that's a dream. So let's start with the scientific side. Most of us here are here to say that we try our level best to deliver evidence-based medicine. And the best form of evidence which comes for this purpose is from properly designed, well-conducted, multi-center randomized controlled trials. And this graph shows that nephrology as a specialty, as a kidney specialty, lags behind such clinical trials compared to other specialties. As you can see, that we are languishing right at the bottom when it comes to doing randomized controlled trial. It so happens that I've got a personal milestone. September 1987, I became a trainee in nephrology. So it's 30 years I've been a trainee in nephrology. And the reason why we don't do a lot of randomized controlled trial is there are two reasons for it. First reason is a personal story that when I started registrar training in my hospital, instead of addressing me by name, they used to call me Captain T. Kirk from Star Trek. And that was the name given to all the renal registrars. So I asked that why? So they said that you guys go where nobody else has gone before. So we used to get asked to look after seriously ill patients, completely unusual clinical scenarios. And we were told that nephrology is a branch which deals with exceedingly rare conditions. And also, we were entrusted with looking after dialysis and transplant patients, which are very complex in their own case. But I just want to give you one bitter fact here, that we have got 7 billion people on this planet. And there are only 2 million people on dialysis in the world. And 90% of them exist in the developed world. So only 10% of the maintenance dialysis patients are in the emerging and poor countries. And there was no commercial interest from pharma companies to do anything about this rare specialty, to do any randomized controlled trial. So that was one of the reasons why we didn't have much of the commercial interest. Second thing, that when we did any randomized controlled trials, because the patients were so complex, they always used to be negative. So we were not very good in choosing topics rightly to encourage pharma company to come and help us doing these expensive clinical trials. Ironically, from one of the negative trials, which was sponsored by NIH USA, we burnt around about $80 million for this trial. It was a negative trial. It was a trial which randomized patients over 800 into low protein versus normal protein diet. And I grew up on that philosophy when I was a trainee. And that was the mother of all trials on this subject. And it basically was negative. But it was a very data-rich clinical trial. Everybody had religiously measured GFRs, routine biochemistries, all the parameters you can think of were measured. And from this data-rich environment, mathematicians from Harvard came up with the equation, which we call MDRD equation, modification of diet in renal disease. That was the acronym for this clinical trial. That gave us a simple way of assessing GFR rather than the nuclear techniques, which is very cumbersome and very expensive. So we got this, and it got adopted by most of the biochemistry labs all across the land and possibly globally. When that equation was applied to the current data sets, which were collected for other clinical conditions like heart or oncology, it became very clear that low GFR is much more common than was originally thought. So then we nephrologists had to come up with some sort of a staging scheme, which was a bit like this, that if your GFR is greater than 90 and you've got no urinary abnormalities, you will be considered as normal from renal point of view. And then if you have got still normal GFR, but the urinary abnormalities, which is protein or hematuria, you will have stage 1 chronic kidney disease. Then the bending went downward, stage 2, with the GFR is 90 to 60. If it is between 60 and 30, it will be stage 3. If it is between 30 and 15, it would be stage 4. And less than 15 means you are end stage and requiring dialysis or transplant. To make it even more attractive, we added proteinuria. So we always use a suffix that if it is stage 3, so for example, somebody's GFR is 45, is stage 3 chronic kidney disease, we will specify whether there is proteinuria, microalbuminuria, or macroalbuminuria. Why did we add protein? Because it became very, very useful for those who don't deal with kidney disease. I just want to highlight one area that if you were to have a GFR of 60 and had no proteinuria, your risk of getting cardiovascular mortality comes to 1.2. That is a hazard ratio. It goes to walloping 4.5 if you have got proteinuria with the same amount of kidney function. And today, even our cardiology colleagues realize that just protein and eGFR, which you get it on your routine labs, is much more powerful predictors of cardiovascular events or mortality than all the cholesterols and all the other parameters put together. So all of a sudden, by doing this, we all of a sudden, from being Captain T. Kirk, became ordinary doctors looking after almost a high proportion of patients. So when this classification applied to all the current databases, it became clear that up to 15% of the people living in the Western world have got some form of chronic kidney disease. That's the origin of CKD epidemic. It was not that we created it, it was just discovering that these patients existed. We didn't even know about it. And all these simple classification was relating to future outcomes. And then statisticians, as they do, started having projecting that what that means at a population level. And that even frightened our previous president of America, Obama, when he saw these numbers, that the lifetime risk in America of getting chronic kidney disease, and that is, I'm talking of 3A, which means GFR of 60 to 45, is 60 to 70%. This is more than somebody developing cancer in the entire life. If you were to even go to the very crude thing, that at the moment there are 13.5 million people, white people, and 1.8 million black people in USA who have got stage 3 chronic kidney disease. And it is quite predicted that 26 million people either have it or will develop stage 4 chronic kidney disease, which is very advanced kidney failure. At that stage, you are waiting to go on to dialysis. So this is very frightening. And as a result of this, we are now become one of the biggest chronic ill health problem in the universe as one of the specialty. And we are bracketed with diabetes, hypertension, chronic kidney disease, cardiovascular disease, and oncology. They have become 5 main areas of chronic non-communicable diseases. 2015 was a turning point in the global health year, and I think you should remember this. This is the first time chronic non-communicable disease have become more common as a cause of mortality than infectious diseases. Up till now, infectious disease used to be far more common as a cause of mortality as compared to chronic diseases. 2015 has seen a paradigm shift towards chronic diseases as the primary cause of mortality in the world. Just to give you numbers, 57 million people died in 2015, of which 63%, meaning 36 million people died of chronic illnesses. Chronic illnesses are those who stay with you for 3 months and never go away, and they're not the one which can be prevented by vaccination or antibiotics. Now, these guys who have died, they have already completed their journey. The frightening thing is, for every chronic disease death, there are other 50 living in the community with these illnesses. What is the impact of those people who are living with those chronic illnesses, which I've told you just now? And the way to measure it, that how many healthy years lifespan was lost as a result of any illness in the world in 2015, over 7 billion people, 2.6 billion years were lost due to illnesses in the world in 2015, of which 1.5 billion healthy lifespan years were lost due to chronic illnesses. What is the implication of that on global economy? 1.5 billion years lost of healthy lost, your productive years lost in 2015, and the cost of that to global economy is $2 trillion. $2 trillion. If this trend continues, we would have spent $47 trillion by 2030. Just to make a note that the global turnover, pharma company turnover, global turnover, the amount of drugs which we buy for our patients is $1 trillion. We are wasting $2 trillion by just healthy lifespan lost. This is not sustainable. It is not sustainable at the global level or any other country level. Just bring one example, diabetes, which is very common in Pakistan. I was there last week, and everybody was talking about that 25% of the people have got diabetes in Pakistan. 25% of the people in Pakistan have got diabetes. So let's talk about it, that what is the economic burden globally for diabetes alone, one condition. 2015, $1.3 trillion were spent just looking after people with diabetes or their complications. I rest my case. This is not sustainable. Okay? And it's very right that Philip Hammond, our chancellor, is losing sleep over these numbers, that we in social healthcare system won't be able to afford in this country, let alone any other country, the sort of carnage we are seeing at the moment. So where did it all come? Where did we go wrong in this modern high-tech? Why did we get ourselves into this mess? That's the question we need to ask and think outside the box. And the answer is on this slide. I've taken the life expectancy of human beings on this planet, dragging them 10,000 BCs. This is well before Moses, well before Abraham. We are talking of 10,000 BCs, well before even pharaonic time. From mummy archives, we have got that the mean age of life expectancy in the universe, or on this planet, was around about 25 years. And it went up to 27 years over the last 10,000 years till the turn of last century. Till 19th century, this was the life expectancy. So you were considered lucky if you lived 28th birthday. This is the mean age. There were people who were living longer, but the mean age life survival was this. In the last 100 years, life expectancy almost tripled, just tripled. And the rate at which it has risen is more than in the last 10,000 years. So our life expectancy is now 80 in developed countries. It's tripled over 100 years. Our genes were not ready for this sudden increase in our life expectancy. And why did we increase our life expectancy? Is very good curvy linear relationship between per capita GDP of a country and the life expectancy. So the highest life expectancy at the moment is considered to be in Luxembourg or all the developed countries like UK is here, USA, and they are living around about 82, 83, and it's constantly improving. A poor country, which is Sierra Leone, which is one of the poorest countries in the world, recently struck by Ebola virus as well, life expectancy is still 35 years. So if your per capita increases, so does the life expectancy goes up. Pakistan is an outlier. And I'm very grateful that all the VCs are here and all the medics who are working in Pakistan. You have proven this graph wrong. Because according to this, with the per capita GDP of Pakistan being $1,629, we would have expected the life expectancy in Pakistan to be around here, around about 50. We have already 66.5 years. We even now know that if the growth rate of GDP, which is projected at 5 to 6% every year in Pakistan, in next 50 years, our life expectancy in Pakistan would be 82. So what we are facing today, you have got 50 years to wait. So you get your house in order now. Now, I'll give you one stark fact, that in Pakistan, in UK, 14,000 people are above the age of 100. 14,000 people are centurion. In 1922, when the royal family sent the 100-day birth, when anybody gets 100 year in this country, they get a royal card, happy birthday card from the royal family. There were 20 cards sent. Over the last 18 years, 14,000 cards were sent by the royal family for celebrating centurions in this country. How the transformation, 80 years. Over 0.5 million people in UK are above the age of 90. And my main basic science research, one of the group which I lead, is aging, and we meet every 6 months with top scientists, and we are saying that those people who are going to live 200 years are already born in this decade. 200 years is not beyond the realms of life expectancy. So in over the 100 years, we will have people who will be living 200 years. The worry is that we are increasing the life expectancy, we are not increasing the healthy lifespan. That is where the hidden catch is, that we have increased the life expectancy, but we haven't made those last 15 years healthy for our people. They're living with chronic illnesses. So whenever the life expectancy increases, it happens at the cost of reducing infectious diseases, the cause of death, which I alluded to recently in my previous slide. So you can see that infections go away, just measles, the waterborne diseases, clean water, sanitation. All the early childhood diseases go away. You live longer, then you have got to live with coronary heart disease, cancers, the dementias, the chronic kidney disease of this world. So if you live long enough, you are more likely to get those conditions. So it is the price we have paid to live longer. So degenerative diseases have overtaken, and that is the cycle. This is where the origin of our chronic ill health has come. What happened to UK when we started this journey? And we have got very good data from going back from 1930. What happened when we got rid of all these, sanitation improved, all these things improved? What happened to those who are living 80 or 90 years today? What happened to that generation? How did they die as they go through their decades? The common cause of this generation was that in the first decade of life was tooth decay. We didn't know that that would be becoming the predominant cause of death in the first decade of life. If you lived that, you survived that, then trauma, road traffic accidents were waiting for you. So the second and third decade, the commonest cause of death in UK back in 1940s was trauma and accidents. If you lived all that, then we ate ourselves into the grave. We became obese. Central obesity was a sign of prosperity. If you look at old Bollywood and Hollywood films, the film hero had a tummy coming out. That was considered as a sign of prosperity because we were living a very mean life. That brought diabetes. With that came hypertension. With that came ischemic heart disease. So the fourth and the fifth decade of life, the commonest peaks in this country were diabetes, ischemic heart disease, hypertension, and in that was chronic kidney disease, which we have realized now after our current classification. Now, initially they used to die, now we are very good, we keep all these people alive, so they now live into the sixth decade. So many patients with these conditions, or those who did not develop these conditions, get cancers. So age of between 60 and 75, the commonest peak is cancer. Now we are keeping them alive, because we have got so good with our therapies. So they live now into the eighth decade, And most of them get dementia, which we don't know what the treatment is. And in the 8th decade, there's an epidemic of chronic kidney disease, because kidneys are not built to last for 200 years. They'll last for 80 years or 90 years. Very simple. We are living too long, but living an unhealthy life to get all these conditions. And I always say to my trainees that life is a sexually transmitted disease. It always ends in death. You determine how you are going to die by how you live. If, in order to say what I've said, there's got to be truth, that if you lived long enough, you would get atherosclerosis. And the proof has come from paleopathology. So when we went to the paleopathology and did EBCT on those, particularly the Egyptian mummies who kept the heart and the kidneys still preserved in the mummies, unlike the Mexican mummies, we could see that if you were 40 or 50 years old, even in prehistoric time, or what you call pharaonic time, you had atherosclerosis. You can see it. That mummies, which were dated as 50 years old or 40 years old, they also had atherosclerosis. So if they lived long enough, they even in those times used to get atherosclerosis. They didn't know how they died, but they had atherosclerosis, evidence of atherosclerosis. It's not a modern disease. It's the disease of getting old and unhealthy lifestyle. Just to tell you that between 75 and 84-year-old gentlemen or women who come to me, if I do their urine test or whatever, around about 30% of them, 1 in 3, have got chronic kidney disease. Now, in UK, get ready, those who have come from Pakistan, that we are doing transplants in 80-year-olds. These are the results. They are as good as somebody who's getting a transplant at the age of 60. We are now using kidneys from our elder senior citizens and giving it to young people to keep them alive. It's working both ways. What are the 2 commonest causes of kidney disease? Diabetes and hypertension. 75% of the chronic kidney disease in UK is driven by hypertension and diabetes. How good we are. So if we prevent those 2 conditions or treat them better, we can prevent CKD epidemic, and as a consequence, you will prevent cardiac. And there is growing body of evidence that hypertension and diabetes leads to premature aging. By that I mean that a 60-year-old diabetic is behaving like an 80-year-old. And they do get a lot of cancers. Rule of halves. What is rule of halves? Half people know that they're hypertensive or diabetes, half don't even know that they're hypertensive. Those who are hypertensive, only half are on treatment, half don't even take the tablets. Those who take the tablets, only half have got appropriate control. That's called rule of halves. This is how good we are in UK with free medicine at source. Guidelines which we propose, we write, it's just a one-size-fits-all. Real life is like this, that you can't apply one law to this young girl or this elderly woman. We have to think outside the box. Our current strategies are, we see the patient and postpone their death. What we need to do is to act much earlier and prevent them. And the prevention starts in utero, at fetal programming. Our beautiful religion, Islam, has says, look after your mother. I understood the meaning today when I was preparing this talk, that it is not only meant for the children of that mother, it is for all of us to look after a mother well and make sure that she is properly fed, so the fetus who is in that tummy gets the proper nourishment, so it doesn't get abnormal fetal programming, and prepare that little child to have a better beginning right from the beginning. So we in our institute, through Life Sciences Centers, are proposing a faculty of lifestyle medicine. We have learned it after 50 years of this carnage, and we hopefully be having a multidisciplinary teams which involves public health experts, social scientists, physiotherapists, nutritionists, behavioral therapists, psychologists, religious leaders. Because I think that we need to teach religious leaders about science. Unfortunately, there is not much comprehension or religious, that if my patients who are Muslim go and I tell them this is the case, they go to the mosque and Imam says, don't worry, Allah will look after you. This is happening in this country, so I bet this is happening in Pakistan as well. So this is the looking ahead. We are adopting all these technologies, and one day we will have a bioengineered kidney going from your own patient's tissue into the kidney, into the patient. That is what we are working in our labs. We are creating regenerative medicine. We will be gene editing, so all genetic condition will become history. We will edit them at birth and treat them. And I personally think that the medicine which we are practicing today is yesterday's medicine. What we are doing in my lab today, if 10% of that becomes true, medicine, what we practice, will be completely different for the next generation. Thank you very much for giving me the chance.